Okay, so finally we're going to talk about muscle pathology or problems. This is going to include muscle fatigue, which isn't really pathology or a problem, but it is a phenomenon you have to contend with. Muscle cramps, atrophy, Duchenne muscular dystrophy, rhabdomyolysis, myasthenia gravis, tetanus, and polio. Muscle fatigue is when your muscle's ability to generate force has declined. You used to be able to move X amount of weight with your arm, but now you can't do quite as much. It's tired. There's two major causes of this: neural fatigue and metabolic fatigue. Neural fatigue is where the nerve isn't able to sustain as strong of a signal as it used to, or conjure up as strong of a signal as it could before. So for example, if you're just starting strength training, I am a super couch potato. If I went to the gym and started lifting hard, my nerve isn't going to be accustomed to stimulating my muscle for very long or for any amount of significant weight. So I'm going to get tired really fast. My nerves specifically are going to stop being able to generate enough of a signal to keep my muscles contracting enough to lift the weight that I'm trying to lift. So the nerve kind of gives out before the muscle fibers are exhausted. The muscle fibers maybe still have a ton more energy to give, but if they don't have a signal coming to them, it doesn't matter. They're not going to contract. In this case, the muscle contraction can become eccentric. You have a straightening of the joint, not a forcible straightening of the joint necessarily, but an inability to contract further. This type of neural fatigue will not result in soreness. Your nerves don't generate any of that lactic acid or anything that's going to cause muscle soreness, and your muscles didn't get tired in the first place, your nerve did. So I will lift a bunch, I will not be able to lift a bunch, and then the next day I won't really feel that bad. Unless I hurt myself, which frankly this is a great way to hurt yourself otherwise. The other cause is metabolic fatigue, in where the muscle fibers are no longer able to contract like they used to. Oftentimes, when you're experiencing fatigue, particularly from deliberate exercise, you're experiencing a combination of the two. In metabolic fatigue, it can be caused by insufficient ATP, glycogen, you don't have enough creatine phosphate, or whatever. These are all different ways of they're all either ATP actually, or ways that are going to contribute to the creation of ATP, if you recall, under aerobic conditions. So you just don't have enough energy to fuel the muscles to sustain the work you want to do. What you'll end up with is a resorption to anaerobic mechanisms. That'll cause a buildup of waste materials, most notably lactic acid, reactive oxygen species, which can do damage to muscles. And the buildup of these waste materials, because these all have a charge to them, right? These are going to interfere with the ability of the sarcoplasmic reticulum to release calcium. So you can't initiate that process of the power stroke anymore, because you can't get calcium in there to shift the change of troponin, to move the tropomyosin out of the way, to show your actin binding sites. So you don't have enough energy to go around in the first place. The means by which your muscles resort to create energy, creates all this crappy waste product. It's going to build up in your muscles. It's going to make you even weaker than you were before. It'll damage the muscles slightly directly, and you'll end up with soreness and weakness. Now, these can be discrete events, but if you're just like going to the gym for the first time or something, or you helped your buddy move and you're lifting couches and you're not used to doing that, you're going to get a combination of the two. The more specific mechanisms than this that contribute to muscle fatigue are pretty incompletely understood, and if you look it up, there's a million other hypotheses as to how this process happens, both in broad strokes, like other types of fatigue generation and in more detailed stuff. These are the two major ways. More generalized muscle weakness, like systemic, like overall muscle weakness, can be from malnutrition, where you're not getting enough energy in the first place to sustain muscle contraction, or you are not consuming enough protein or enough calories, period, to create the amino acids, to create proteins, to build muscle mass in the first place. Neurological disorders, so like polio, for example, if you're not sending enough of a signal to your muscles in the first place, you're going to have muscle weakness, and eventually that can cause muscle atrophy. Before we get to atrophy, we'll talk about muscle cramps. I choose to not look at this picture to the left, even though I'm the one who put it in there, because it gives me the heebie-jeebies. It shows this like really serious, huge contraction in this poor guy's calf that looks so uncomfortable. A muscle cramp is a sudden involuntary muscle contraction. It's a contraction that is induced that you didn't intend to create. It often comes while you're contracting a muscle, but the extent to which this certain cluster of muscle fibers, this certain number of fascicles, whatever, are contracting is not something you intended to do. Muscle cramps are, I think we all know, are painful, but they are temporary and they are not inherently damaging. Now, the reasons that contribute to why you're getting the muscle cramps may or may not cause damage, may or may not be representative of other damage done, but a cramp in and of itself isn't damaging. This can be caused by fatigue or by insufficient electrolytes. So for example, we talked about sodium as being a major player in the generation of an action potential. It's going to be a major player in the generation and propagation of an action potential in the axon itself and down the length of the sarcolemma. If you don't have enough electrolytes, you're not going to be able to cramp or you're not going to be able to contract normally. So in particular, that movement of sodium that creates an action potential that's going to rush down the T-tubule is going to allow for the movement of calcium. Now, when the sodium-potassium pumps are stimulated, they're going to also stimulate these fast calcium pumps that lets calcium out into the cytoplasm quickly. If you don't have enough sodium and you don't create enough movement of those ions, the calcium kind of can't leave by the fast calcium pumps. There's separate calcium pumps that are stimulated by completely different stuff that also pump calcium, but they're slower. And so instead of having this rush of calcium that enters into the cytoplasm, you end up with this slow trickle of calcium that can end up causing sort of a slow hold of a contraction in a given area. This is also incompletely understood, and there's controversy about the mechanisms, etc., but this is the prevailing one. It can also be caused by insufficient ATP. So like if you don't have enough ATP, you can't release those myosin heads, so they stay locked on and pushed forward. It can be caused by dehydration, by hypoxia, by hyperflexion. It can be a symptom of an overlying disease like renal diseases, because that causes ionic balance issues in your body. Metabolic diseases for the same reason. Can also cause muscle cramping. So again, while muscle cramps themselves aren't a problem, they may point to a larger problem. Atrophy is a decrease in muscle mass due to restricted or limited movement. Remember, use it or lose it. If you're not using muscle fibers, you're not going to bother maintaining the mass of those muscle fibers. You're not going to contain as many myofibrils as you used to. Whole muscle fibers might plain die off. This person had a cast on their leg, and that part of the leg didn't move for weeks or months or however long at a time. And you can see that your body, or this person's body, went, oh, we're not moving the muscle anymore? Okay, well, I don't know, we'll strip it for parts and use it for other stuff. And so the muscle mass over here is a lot less than over here. So if you set a bone in a cast, that can cause atrophy. If you're bedridden and you just plain don't move a lot, period, your muscles will atrophy. If you're in long-term hospital care, if you're in a nursing home and you're not being properly motivated to get up out of bed and stuff, your muscles will atrophy. Heck, I'm recording this video in spring of 2021. COVID started in the beginning spring of 2020, And I've done a heck of a lot less with my body in that lockdown time than I ordinarily do. And I am weaker as a result of it. I can feel when I get up and walk around that my body isn't as used to doing that as it was before lockdown started. And when I go to pick up my backpack, it feels a little heavier than it used to. My muscles have gotten weaker, so these forces have a bigger impact on the load that my body perceives and the fatigue I'll experience. So that's a, change to sedentary lifestyle. That's me. This can set in really rapidly. You might not notice it for a while, but the process begins fairly quickly. Again, your muscles consume a lot of energy. They make a ton of ATP all the time to sustain themselves. If you're not using them, that's a quick and easy place for your body to just say, okay, we're taking stuff out of here instead, because if we're not going to spend all this energy on something that we're not using. It's like if you had a bunch of bills, that were all optional, and you had like one TV subscription that's like $100 a month and another like a Netflix style subscription that's $12 a month, and you suddenly lost your job and you had to pick which one you're going to get rid of. You're going to get rid of the $100 one first. You're going to get rid of the expensive energy stuff first. Muscles are energetically expensive, so if you're not using them, your body's going to stop maintaining them. So it sets in rapidly. You may not notice it for a while because you have so many muscle fibers in any given muscle, but it does start quickly. This can also be caused by neurological impairment or a diseased motor neuron. You may be moving around just as you always have, but if you have nervous system damage, you're not going to be able to generate a stimulus to a muscle fiber to get it to contract. And when that muscle fiber doesn't contract for a while, your body's going to do the same thing. It's going to say, oh, we don't need to maintain this anymore. Let's strip it for parts. Duchenne muscular dystrophy is a sex-linked recessive genetic disorder, and about 1 in 3,500 babies born are affected in the affected sex. Now, which is the most commonly affected sex? Remember, sex-linked recessive. Think back to your biology. Male chromosomes, sex chromosomes, are an X and a Y. Male. Females are XX. The Y chromosome really only has enough information, big fat asterisk, because there's information coming out that kind of contradicts this, but it's pretty new. Overall, though, the Y chromosome only kind of has enough stuff on it to create maleness. Okay? The X chromosome carries everything else. All the other regular chromosomal stuff that you would find in any given chromosome. You're going to find that same amount in the X chromosome. You get one chromosome from mom, which is always an X because she only has X's to give, and one chromosome from dad. And since males are XY, the sperm they give might be an X or it might be a Y. So the mother's contribution is always the same. It's an X chromosome. The males can contribute either an X or a Y, and ultimately it's the sperm then that decides the genetic sex of the baby. So if an X chromosome has lots of stuff on it and a Y chromosome doesn't, they come from two different parents with two separate sets of genetic information. X chromosome with lots of stuff on it, X chromosome with a separate set of lots of stuff on it. If your X chromosome has a problem that causes, or a mutation that causes Duchenne's muscular dystrophy, let's say mom gave you that X chromosome that's mutated. If your father contributed a sperm with a Y chromosome, the Y only does maleness related stuff. So what's showing up in your body is the X chromosome. If you're a female, because your father's sperm contributed an X chromosome, if he's not a carrier of this, Then you'll have one chromosome with the mutation and one that's not. And when this sort of thing happens, by processes that are frankly mysterious to me, the less problematic one wins. So this can still be passed on to your kids, but this is how you will look, a non-diseased state. The male chromosomally can only show the diseased state. So overwhelmingly, sex-linked recessive diseases affect males. This is not exclusive, but overwhelmingly it affects males. The color blindness is another sex-linked trait, which is attached to the X chromosome. It's sex-linked recessive. Men are way more likely to be colorblind than women are. But if you have a woman who is conceived by two colorblind people, she can be colorblind. Or a colorblind father and a mother that carries colorblindness. She can be colorblind. It's just way less likely. That's all. So sex-linked, Duchenne muscular dystrophy begins at the proximal aspect of the limbs, so the root of the limbs, and radiates outward through the limbs. And this is like a weakness, an atrophy that progresses. Usually it starts to show at about age 4 and advances terminally. There is no end to this disease. It will be with somebody for their whole life once it's set in, and it is unavoidable once you're born with those chromosomes. Most people with Duchenne muscular dystrophy lose the ability to walk by about age 12 due to weakness in their muscles, weakness in their limbs, and contractures and deformities that are formed in the muscles by years of progressive weakness and atrophy. Eventually, the disease will radiate outwards in towards the trunk, or inwards towards the trunk, and the diaphragm and the cardiac muscles are affected. Once that happens, you're no longer able to pump your heart, you're no longer able to breathe, at least not effectively enough to sustain your life, and that will kill you. The average life expectancy is 26. With proper physical therapy, braces, etc., you can live over 30 with this disease. This is something that is something you can test for genetically prior to birth, like in the first trimester of fetal life. So this is because it is crippling and causes premature death after kind of a really excruciating existence. Many people, not everybody of course, will terminate the pregnancy if this comes up positive. So the rates of this actually showing up have declined somewhat. It's not necessarily because the genetic instance isn't happening as much, it's that termination is more accessible than it was, say, 70 years ago. And genetic testing has advanced since then so that people can tell before the baby's born whether or not they have this excruciating terminal disease. The way it happens, the genetic problem, the chromosomal problem, causes a problem with the person's dystrophin. Remember what dystrophin does. It attaches the cytoskeleton to the extracellular matrix, and it helps anchor cells. It also helps anchor sarcomeres. It permits excess calcium to enter the cells and helps maintain the osmotic balance of mitochondria. When you have the osmotic balance of mitochondria upset because you have so much of this ion into the cells, they're going to burst. Without the energy generated by the mitochondria to sustain muscle contraction, you're going to die, or the muscle fiber is going to die. Use it or lose it. You don't have enough energy to sustain the muscle fiber. Your body's going to say, well, if you can't contract, we don't need you, so it's going to get rid of it. Muscle tissue is then replaced by fat and connective tissue, and because of that, a patient's muscles can seem artificially enlarged, but it's not because of actual muscle mass, it's because of this replacement. Again, it can be detected during pregnancy. We're in the very beginnings of trials for gene therapy for Duchenne muscular dystrophy, where you can perhaps alleviate this person of their condition at a genomic level, but it's in its infancy. It's not a realistic option for somebody to consider for most people at this point in time. Rhabdomyolysis is a condition in which skeletal muscle breaks down rapidly, and so you end up with this sudden influx of myoglobin into the blood. When the myoglobin enters the blood, it's going to get filtered by the kidneys. Blood gets filtered by the kidneys. Now this blood has a ton of extra myoglobin, and that's super, super hard on your kidneys. So it can cause problems within the muscle itself because it's breaking down rapidly, and kidney failure. The process of kidney failure and the problems with your muscles are going to cause symptoms like this: muscle pains, weakness, vomiting, confusion, tea-colored urine because of all that oxygen-rich myoglobin making its way out into your urine because your kidneys can't keep up with it, and irregular heartbeat, again, because you've got all this extra stuff in your blood. Causes can vary quite a bit, but overall the trend is you have so much being forced into your muscle so fast that it can't sustain its basic architecture effectively, and it ruptures at a molecular level. So crush injury, for example, if you have a car runs you over, you're crushed under the car, your muscles are going to rupture and they're going to release all this myoglobin into your blood. This is a really big problem with finding earthquake victims. So, and it's a big problem with recovering people from and saving them after earthquakes. Even if you do find them, a lot of them have these crush injuries and then they don't make it very well. Some infections can cause it, drug abuse can cause it, certain medications can potentially cause it, particularly in overdose, larger than prescribed dosage. A severe increase in exercise suddenly has caused quite a bit of an uptick in rhabdomyolysis in recent years. It's been known to be a problem in basic training in the military for a really long time, where you have these like teenage couch potatoes that, they don't do anything, and then you send them to basic training and they need to be exercising quite strenuously for, 12 to 16 hours a day. That's hard on your muscles, and they tend to just break down super fast. More recently, we have an uptick because of these super high intensity exercise trends, and CrossFit in particular is known for inducing this. If something is advertising that it's going to make you barf, it's working you out so hard, it's bad for you. Maybe it'll get you into shape faster, but it'll also destroy a lot of your body in the process. And this is a real risk with stuff like a couch potato just joining CrossFit. Electrical injuries can cause this. Heat stroke, snake bites, lack of blood flow to a limb, the DTs, the delirium tremens that happens after sudden alcohol withdrawal can also cause it. So it's not, there's a lot of different ways you can get to this problem, but ultimately your skeletal muscle has to be induced to break down quickly. Maybe you're injecting something into it that it can't handle. Maybe you're requiring a buildup of something. Maybe you just shock it to hell. Maybe you heat it too much. Maybe you have poison. Whatever it is, if that skeletal muscle breaks down, it's going to release the myoglobin into the blood. A sudden rush of all of that into the bloodstream is going to be hard on your kidneys, and they're going to shut down. Treatment involves lots and lots and lots of IV fluid, basically to dilute your blood so your kidneys can handle it. You may require dialysis so that your kidneys can survive long enough, so that your kidneys are getting extra filtration help and kind of tide you over until your myoglobin levels are in your blood are low enough that your kidneys aren't going to have a problem with them anymore. If you catch this early, the prognosis is really good. If you have a car that runs you over your leg, that's crushed, you're starting to release myoglobin into your blood. When you go to the ER, they're going to be screening you for this. They're going to look for the first sign of it, and they're going to slap you on an IV with dialysis quickly. If there's more major trauma, if you're left with the trauma untreated for a long time, if you already have kidney disease, your prognosis becomes worse. Complications of rhabdomyolysis include issues with ion balance. Again, you're releasing a bunch of stuff into the blood. It's not just the myoglobin that you're releasing, that's what's causing the major kidney problems, but you're releasing everything else. So you're releasing a bunch of calcium, and a bunch of sodium, and a bunch of potassium, and that can cause ion problems. Plus your kidney isn't working as well as it should to keep your ion balance where it ought to be. So you have a double whammy there. Compartment syndrome, where you have one region of muscle that is going to inflame and within a connective tissue sheath and choke itself off. And because it's so kidney heavy, kidney damage. And that kidney damage can be pretty permanent if it lasts long enough and it's hard enough on your kidneys for long enough. Myasthenia gravis is a condition of long-term neuromuscular disease characterized by skeletal muscle weakness, most often in the eyes, face, and in swallowing. The onset of this is typically quite sudden. You're fine one day, you're not the next. It's more common in people with an enlarged thymus gland, men over 60 and women under 40. And it seems to be caused by an autoimmune reaction against your ACH receptors. So you have your skeletal muscle, your axon will send its electrical zap. You'll bundle up calcium. The calcium will bring in calcium. The calcium will bundle up your ACH and release it into the cleft. Now that ACH has to bind with a sodium-potassium channel on the sarcolemma. If your immune system is making antibodies that are attacking those channels and binding to the channels, it's not going to be able, the ACH can't bind to it and can't open it. It's effectively locked shut. And since it's locked shut, you can't stimulate that action potential that'll stimulate those voltage-gated calcium channels in the sarcoplasmic reticulum that'll release calcium into the myofibril and then cause contraction to start. So it cuts the whole process off right at the beginning of the muscle part of this process. It's not systemic typically. It happens in regions, and again, most often in the eyes, face, and it causes problems swallowing. Treatment involves immunosuppressants. If this is an autoimmune problem, then suppressing the immune system can help. Acetylcholinesterase inhibitors. This is an enzyme that breaks down ACH. So by inhibiting those, you can make sure that you have as much ACH there as possible so that whatever channels can work, do work. Thymus removal can help. The thymus is involved in maturation of T cells, immune cells that are, they mature in the thymus, and that's why they're called T cells. But just remember that for immunology next semester. It can happen anywhere. Again, it most commonly happens in the eyes, face, and with swallowing, but the diaphragm can become involved. If the diaphragm ends up being involved, then you will require mechanical ventilation while you are starting immunosuppressants and starting other treatments to help relieve this problem. The disease tetanus, characterized by sustained tetanus state in a person's muscles, is caused by the toxin released by the anaerobic bacterium Clostridium tetani. Again, right now we're talking about the disease characterized by tetanus state. This anaerobic bacterium, when it gets into a wound, they often talk about puncture wounds because those are big and deep. When the inflammation sets in around the wound, if it's a puncture wound, it's just a straight line in, then it can swell shut basically and trap whatever bacteria is in there in an anaerobic environment. And the Clostridium tetani really loves that and will take off quite quickly, releases its toxin, and this causes paralysis. It binds to the peripheral nerve endings. It's then transported down the length of the axon. So these peripheral nerve endings, like in the skin or something, it'll transport down the axon all the way up to your central nervous system, and then it'll fix to inhibitory motor nerve endings. So you have some motor nerve endings that are stimulating and some that are inhibiting, and it fixes to the inhibiting ones so that only stimulatory ones work. So you only have contractile signals going to your muscles in the first place. You don't have any relaxation signals going to your muscles. So when your muscle contracts, it stays contracted. It doesn't let up. This is going to spread throughout your body, and eventually it'll affect your diaphragm and your heart. You won't be able to breathe or pump blood anymore, and you'll die. This is much more frequent in hot, wet climates, but it's abundant everywhere. You shouldn't think that just because we don't live in the jungle that you're not going to get this. It's everywhere in the soil. It is not communicable between people. It is communicable predominantly through the soil and contamination that way. So if you were exposed to the same soil, you are similarly injured, you could get it too. But if your friend has tetanus, you can't get it from them. It is 100% preventable because of vaccines. And this vaccine in particular works beautifully, just beautifully. And preventing the toxin from binding in the first place by your body being able to react quickly and breaking down the toxin before it gets to do anything. The rate of sickness with the tetanus disease has plummeted in the last 50 or 60 years, or however long it's been since this vaccine was conjured. I can't remember right now off the top of my head. But it used to be it was never that common exactly, but you would kind of know or have heard of somebody who might have died of tetanus back when. And now it's, like in the low thousands, I think, maybe hundreds, that people die of this disease in the United States. And it's mostly people, like older people, who just haven't bothered getting their tetanus boosters for one reason or another. If you do contract this and you're unvaccinated, your symptoms are going to start anywhere between 3 and 21 days after infection, depending on how quickly the bacteria can divide and release its toxin and how sensitive you are to the toxin. The further away from the central nervous system you are also correlates with a longer incubation period. So if you have tetanus that's starting in the tip of your toe, it's going to take longer to set in than tetanus that starts in on your shoulder, because your shoulder is a lot closer to your spinal cord than the tip of your toe. If you actually contract it and you are appropriately treated with mechanical ventilation, with muscle relaxants, with immunoglobulin against tetanus, if you are treated, 10% of you will still die. It is excruciating in the meantime. And without it, it is 100% fatal. You start with lockjaw. You might have heard about tetanus causing lockjaw. It typically starts symptomatically with your inability to open your jaw. And the spasms will then radiate across the face, down the torso, and down the back. And eventually, like I said, your heart and your diaphragm will become involved and you'll die. And then that last slide, I was wrong. I was thinking of global numbers or developed world numbers. Since we've had this vaccination be regularly administered in young people and boosters, this has resulted in a 95% drop of disease, more than 99% reduction in fatalities, and in the United States, we've been averaging less than 30 per year before 2009, again, in mostly old people. Incidence is slightly increasing very recently, and that because it's due to anti-vaccination efforts. So you have this small dose of inactivated toxoid that's administered, your body becomes sensitive to that, it develops antibodies against it, and so when that actual toxin is introduced into your body can fight it quickly before it gets to do any damage. This was developed in 1924, but it wasn't available in the US until the 1940s, so I guess more like 70 odd years, 80 now. I'm getting old. The major reaction with the tetanus shot is discomfort. Any other kind of serious side effects happen at less than 1 in 100,000 rate. The rate of contracting the disease back when was much, much higher than that. So this is a real obvious risk-benefit choice to make. If you're offered the opportunity to get a tetanus shot, you should get a tetanus shot. If you go to the emergency room and you have a wound and they say, hey, when was the last time you had a tetanus shot? And you go, while you're thinking about it, they're going to just give you a tetanus shot in the meantime. They're going to say, if you can't remember off the top of your head, it's long enough ago that we can't risk it. And they'll just give you a booster, and you will be no worse off for having that booster. Usually when you get it in a routine basis, certainly, it's administered with diphtheria and pertussis as a combo vaccine. In grown-ups, it's a TDAP. Tetanus, diphtheria, and acellular pertussis. You get a dose of tetanus toxoid, diphtheria toxoid, and pertussis cells that are broken down into bits, acellular pertussis, so that your body can become sensitized to those antigens on the cells, but the cell isn't intact, so it can't live. You get your first dose of this before you're even born, because your mom gets this vaccine when she's still pregnant with you. She can then transfer those antibodies to you through breast milk. The baby will get it again, and in utero. The baby will get it again at 6 weeks. You'll get it 3 or 4 more times through childhood, once in adolescence, and then about once every 10 years in adulthood. Typically, most doctors don't like to let you go more than 7 years for this, once every 7 years for this. But again, it's one of these things where like you kind of can't, it'd be hard pressed to get it too much. If you ever have to think about when the last time it was that you got a tetanus shot, you should probably just get a tetanus shot if you find yourself in the emergency room. Poliomyelitis, polio for short, is a virus in the family Picornaviridae and the genus Enterovirus. The word entero is related to enteric, or comes from enteric, which refers to the gut. It's transmitted then by GI-related route, the fecal-oral route. You consume in your mouth somehow some small amount of feces-derived particles, and then you inoculate. You didn't wash your hands well enough, for example. You accidentally drank some pool water, whatever. You consumed feces particles somehow, even if it was just a couple and you never knew you did it. This is also a 100% preventable disease. There is has been for a very long time a vigorous vaccination campaign that has been overwhelmingly, outstandingly successful at, in many places, eliminating polio outright. Polio is extremely contagious. The R0, which many of you are familiar with now since COVID, but that's your basic reproduction number. If you are sick with this, how many other people can you expect to make sick? Is 5 to 7. So if I find myself with polio, I'm contagious for a little while before I'm sick, right? That's how most of these things work. So before I get sick and even think to hide myself away, I will have on average gotten 5 to 7 other people sick. That's a pretty high number. That's up there with smallpox, which you think of as sort of the worst plague known to man, right? The 1918 flu was like 2 to 3. This is a really, really contagious disease. It colonizes the GI tract after anywhere from 6 to 20 days. So you consume it somehow on accident and it takes hold. It takes anywhere from 6 to 20 days to really take hold in your gut where it's reproducing vigorously. If you are immunized, or if you have been sick with it and survived, you are conferred lifelong immunity. This is not guaranteed with every disease. Lots of things you need boosters for, like tetanus. And there's a lot of different reasons that go into that. It's not an immunology course, so we won't get into that. But with polio, at least, once your body has seen it, either by vaccination or you have gotten sick and survived, you'll never get it again. Polio paralyzes people. There is no cure for polio as well. The treatment that there exists is only supportive. So you start off with flu-like symptoms, just like practically every disease known to man, right? You start to get sick because the feeling of being sick more comes from your body's immune system ramping up and you reacting to the disease rather than caused by the disease itself. So you start off with these flu-like symptoms, that's your body kicking into gear. And it progresses to paralysis. Now, how the mechanisms of the virus move from the virus being in your system and in your blood, to the central nervous system, and how it causes paralysis after that is not very well understood at all. There are hypotheses, but it's still up in the air. Polio most commonly affects people's legs, and in many people it affects your legs and then is resolved. And sometimes it can resolve sufficiently if it was a short enough of an instance that you can walk and be fine again. Dick Cheney, for example, had polio when he was a kid, I think. He walks around fine. Sometimes it can progress further than that. Sometimes it can take hold for a long time. If it takes hold and you're paralyzed for a long time, you may need supportive help in order to walk around. You may need a brace, or you may need crutches for the rest of your life, or a wheelchair. If it progresses more superiorly than your legs, you're going to need more intense supportive therapy. So the lady in the bottom right corner is in what's known as an iron lung. It's opened up so you can see her, but basically what that does is it breathes for you by changing the pressure in the chamber. When the pressure in the chamber, this sealed up tube, releases or gets lower, your thoracic cavity expands and you're forced to inhale. And when the pressure comes back into that tube, the pressure against your thoracic cavity increases and you're forced to exhale. That's how you breathe, because your diaphragm doesn't work anymore. It's paralyzed. The muscle may or may not rebound, and if you catch it as an adult, it's far more lethal than if you caught it when you were a kid. Again, treatment is purely supportive. There is no cure. You can keep people alive for a really long time on an iron lung, though. That's mechanical ventilation. You may have physical therapy elsewhere to make sure that you don't atrophy places the polio doesn't affect. You may need pain medication, because the constant atrophy of this can cause pain. You're more prone to stuff like bed sores, for example. And you may need antibiotics to prevent the muscle that's wasting away becoming infected. On to the vaccine. There's two main types of the polio vaccine. There's live attenuated and inactivated. We kind of went from live attenuated to inactivated and then back to live attenuated based on risk-benefit statistics. So we developed in 1950 a live attenuated polio, where you have live polio that has in a lab been severely weakened so it shouldn't be able to cause you disease. This proved to be extremely effective, but because it is only weakened and not dead, it can and did cause some very, very, very few active infections. Attenuated means weakened. In 1952, Jonas Salk developed the inactivated polio vaccine, where you have flat out dead polio. Dead polio can't come back to life. It's not magic, so it is incapable of infecting a person. It turned out that this was slightly less effective than the live attenuated polio, but it was incapable of infection. And that made people a lot more comfortable taking the vaccine. So really, the one that has saved at first so many lives, that got people excited about vaccinating their kids, getting vaccinated themselves, was this one. Jonas Salk is often credited with inventing the polio vaccine. Strictly speaking, that's not true, but it is the big one, the one that really got people on board with taking it, and the one that really gave the world a huge benefit. In 1958, there was developed a live attenuated vaccine that was new. This caused a strong and sustained immunity, very, 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 very effective, and basically incapable of causing disease. So even though it's alive, it can't cause you disease. So you have all the benefits of the live attenuated and all the benefits of the inactivated into one vaccine. What happens here is you take the virus and you pass it through a non-human animal. You pick a non-human animal whose body temperature is significantly lower than our body temperature. Now, things that can infect us have to like living in us, right? So the diseases that infect us like things to be humid. It likes things to be dark. It likes things to be 37 degrees Celsius. If you put a disease, a pathogen in you that does not like to live at 37 Celsius, that instead prefers to live at 20 Celsius, it's just going to die. It's never going to make you sick. So what we do is we take a virus and we pass it through a non-human animal whose body temperature is lower than ours, substantially. This is going to select for viral particles that can colonize the gut, but is too weak to get to the central nervous system. So it can still get in us and it can spread a little because it is alive, but it does not like being there. It is not happy at 37 Celsius. And so it can't continue on into the central nervous system. It can't progress any further than that. It still does occasionally cause infection, but at rates that are so low that it's not necessarily meaningfully a risk. This provokes a really strong and sustained immunity, and for practical purposes, this makes it impossible to get sick. And it's been the only one used since 1962 through most of the world. There are some places that still will use the inactivated version, but overwhelmingly the world uses the new live attenuated version. The incidence of developing polio with this vaccine is so low that the reversion to paralytic polio is greater than the wild infection rate now. So we have reduced by our vaccination measures the rate of polio contraction in the wild, our chance of just coming across polio in the wild, that this extraordinarily minuscule rate of infection is higher than your chances of getting it if you were alive in 1940. That is really, really amazing. And for that to be a global statistic is really incredible. It can be very, very hard and very expensive to get vaccines to less developed countries who maybe don't have the same refrigeration systems that we do, where transportation takes a long time, where medical staff is limited. That's a really extraordinary achievement. Because the wild contraction rate is so low, we now only very, very recently have, some developed countries have switched back to this, which is less effective, but doesn't even have this minuscule risk to it. Only as long as vaccination efforts continue at the rate that they have been is this the case. With reduced vaccination in any major part of the world, it doesn't even have to be over the course of the whole world. It can be one small region or even one country. If you reduce vaccination, polio vaccination, or any vaccination below a certain point, wild infection, natural infection is going to take off. And once wild and natural infection takes off, you start decreasing the effectiveness of the vaccines in the world. You change this balance of risk and benefit substantially. So whenever you hear about vaccines working for this, vaccines working for that, this is the rate that people get sick. People used to get this before, now we've vaccinated people for a while, now it's not a problem. You should know that it is only not a problem as long as people sustain vaccination efforts, as long as people continue to get vaccinated at rates that they have in the past. Decreased vaccination eliminates herd immunity. It can then take off. It can then mutate, because viruses love nothing more than to mutate. And when viruses mutate, not only have people been getting sick in the meantime that didn't have to, that would have been protected by herd immunity, but now vaccinated people will be able to get sick because the virus will have mutated in such a way that our immune systems don't recognize it anymore. So that's my soapbox. Get your shots, kiddos.